All right. So today I am thrilled to be able to introduce to you all my dad, Joe Mamlin. He spent a career as an internal medicine physician at Indiana University and was chief of medicine at IU for almost 30 years or so, right? A long time.
About 30 years.
About 30 years. And toward the end of his career, the world of internal medicine was being shaken up by the introduction of diagnostic related groups, or DRGs, which changed the reimbursement structure. And as I've heard you say many times, people went into ologies. And for internal medicine, it meant that it was hard to recruit people to internal medicine when they wanted to make money through radiology, cardiology, other disciplines. And so Dad had experience as a Peace Corps volunteer in Afghanistan and went with colleagues to look at international health before most people were thinking about international medicine or global health. So that was in the late 80s. And they ended up creating a partnership with a new medical school that was starting in Eldoret, Kenya at Moi University. And that partnership has grown since 1989, 1990, yeah. Right in there, right? Into something that really is now a transformative model of what academic medicine and ministries of health and populations working together can do. So I've invited Dad here to talk about being a leader in thinking about how to make big things happen, because that's what he's spent his life doing. And in particular, they're getting ready to do some really monumental things in really understanding population health. So I'm going to ask you to talk a little bit about what you're doing.
Well, let me maybe give it a little bit of context. In a way, I didn't start out to do any big things. They fundamentally trying to get hold of some values that are important. A good example is when I finished my residency in medicine at Indiana University. I had two offers. One was to do a cardiology fellowship at Duke and in fact, the university was going to pay me a faculty salary while I was doing that. And the other was an offer of $75 a month and a bicycle to go help start a med school in Afghanistan. And it tells you a little bit about our family wiring when that was a no-brainer. So my wife and our three kids chose the bicycle and the $75. But it was a wonderful experience for me, being the only internist for about 20 million Afghans. Gives you a pretty good sense of how to organize your life in different ways. And fell in love with Afghanistan. And it's through that experience that I at least began to feel part of the larger global community, even though I did return to Indiana University for much the rest of my career, but I insisted that I keep a little of my time abroad. So I worked back and forth in Afghanistan from Indiana with that med school until the Russian invasion of Afghanistan. Then I tried to work with refugee camps in Pakistan, thinking soon I'd get back into Afghanistan. But history can sometimes thwart even your best ideas. And it's obvious we would never be able to return to Afghanistan. And history has shown over the years that that was true. And so still needing to be partly abroad, in 1988, we looked for another spot in the world. And that's when one of your colleagues on the phone from Ghana, we spent some time in Ghana, in Kumasi at the medical school there. We spent some time in a med school in Kathmandu in Nepal. And then in Western Kenya, where they were thinking about opening a second med school for Kenya. I must say, for the sake of those who get to know your Ghanaian colleague, it's one of the most difficult things in the world is to eat the wonderful pineapple in Ghana and then decide you're going to go elsewhere to do your work because there's no better pineapple for breakfast than in Ghana. But anyhow, we chose Western Kenya, where we were there from the first day the med school opened. Now, this, I think, I know Vaughn talks about leadership and vision and things like that. I think one of the first things that comes to my mind, we went there really with the goal of helping Kenya establish a second med school, with the intent that in doing so, we would create a venue where medical students from the US could experience something of sub-Saharan Africa, and also African students could come to Indiana or other partner schools. Well, that's what we set out to do. But I think one of the things, I don't know if I've said this to Vaughn before, is when you set out to do something, it's good to stay vulnerable a bit, because decimal points change to different locations and priorities change. And I think most of you know that going to start a med school in the late 80s and around 1990 in Western Kenya put us in the middle of the worst pandemic in recorded history, the HIV pandemic. And the truth is, that was never discussed. When we went to help set up a med school, I don't think we even discussed the issue of HIV. It was not big on the discussion for anyone at that time in 1988, 1990. But I can tell you that when I spent a year in Kenya rounding on the wards in 1992 for a year, I rounded on all the medicine service and lost about 85 patients that year. And then in the year 2000, when I returned to that same ward, instead of losing 85 people, I lost well over 1,000 on the same number of beds. You don't even need to have a detailed course in statistics to understand something horrible is happening, and happening across much of Africa. And so suddenly we realized we had to raise some questions beyond just going to help start a med school. In fact, it's absurd to be surrounded by young people dying all around you and failing to respond to it. And so our vision changed then to another vision of how can we engage with this country, this Ministry of Health, this threat, and be of some help. And that led to another new phase of my life. I started with one patient. I had the opportunity to treat the very first patient in the year 2000 that was treated in Western Kenya. And it turned out to be one of our fifth-year Kenyan medical students. And so from one patient, we've got money where we could do 40, then we got money to 200, and jumping ahead, we're now in 500 clinics across Western Kenya, have enrolled over 200,000 people with HIV, have been running one of the largest HIV clinics, certainly in Africa, if not the world. Where my office sits, the clinic where I saw the very first patient, the building we built around that, I realized as I sit in that clinic, it's now that clinic of that building is the largest HIV clinic in the world. But it all started with one medical student, and then just following the pressure of the moment and expanding your imagination around what needs to be done. Now, that sounds like, now, goody, you've done something. And the truth is you haven't. All that does is expose you to the world of possibility that we ought to be about. Because to do HIV meant we had to get into the village, we had to go door to door, from house to house to find people, begin to task shift care out to the villages, form village groups. We ended up doing things we never heard of that were essential if you're going to do the job. But in the process of doing that, you begin to realize there's more out here suffering than just HIV. In fact, the monster that we have to deal with has really got more than one head. And it's got hunger, It has poverty as well as disease. And we couldn't fight that monster without backing up again and broadening the vision. Now, first it get beyond building a med school, then it was getting beyond responding to an HIV pandemic. Now the question is, with the experience we've had and what we know now, how do we respond to an entire population? Maybe I can stop there for a moment and see, I don't know, Vaughn, if you want interactive questions, and then I can go on to where we're going from there.
If you guys want to ask questions about that, and then we have a graphic that I'll put up, but that gives you a kind of a sense of the trajectory. Everybody's blacked themselves out.
I don't blame you. I would opt for that if I could.
There's Robin.
Yep. Could you speak a little bit about some of the assistants that you had, so others that went with you or assistants that you had locally?
Well, first of all, thank you. I'm saying this saying, look what I did. I didn't do anything. I worked with a lot of wonderful people. And from the very get-go, this is a Kenyan problem. It's a Kenyan environment. We work in the Kenyan medical school. We joined with the Kenyan tertiary hospital and then joined, in fact, that's kind of the core of what we became. It is a consortium of North American universities working through Indiana University, where I come from, then in partnership with a national medical school and a national referral tertiary hospital. And those three together formed what we called AMPATH. And then we did what I think is one of the best things we ever did, is we kind of walk over and knock on the door of the Ministry of Health and say, your mess is our mess. How can we help? And essentially, as academic institutions, we put something out front that I don't think our universities ever thought of before. We say care leads the way. We will develop excellence in research, excellence in education, but in this environment, care needs to lead the way. And so, in kind of response to your question, the providers, the system is all Kenyan, from the Ministry of Health, the medical school, the tertiary hospital, the people at the county level, even the people at the village level. We increasingly become just enablers, dreamers, grant writers, kind of laughing together and crying together to move this thing further down the road. So it's a large, we started with just 3 or 4 of us. We now have over 2,500 employees in the organization, all Kenyan, and it's all under Kenyan leadership. The first grants came to Indiana University many years ago, and these were large grants, some $65, $70 million at a time. The last grant for $75 million, it went to our Kenyan colleagues, and they now run the whole thing. This whole process has evolved into a Kenyan-led operation, and we're there trying to avoid messing it up, and we cheer for them as they succeed.
Are there other questions out there? You can ask another one, Robin, if you want.
Anything.
Yeah.
Yeah, I'll give some others a chance to chime in. That's exactly what we've heard about in public health, is making sure that we engage local leaders for the sustainability.
Yeah.
That's one of the thankful things I learned many years ago in Afghanistan. I remember very well when this is one of the, if you can imagine Afghanistan in the 1960s, don't try.
Well, mom actually did a calculation when we were there. I still remember. She looked at their technology and what they had, and she figured out they were in the 1400s.
Well, whatever. That matches.
About right.
That matches the Islamic calendar. That's okay. But anyhow, but having a limousine come up to the door, and a uniformed person come to my house and say, the Queen. Now we're in a land of king and queen. The Queen is ill, and they want you to come see her. And I paused a moment and I said, I'm sorry. here are the names of the 3 Afghan doctors I'm training. And you can go to any one of them. If one of them calls me, I'll come immediately, but I'll never walk around in front of them. And I've carried that lesson with me everywhere I've gone, and it's paid off well.
Victoria, I just want to do a quick check. Does somebody else have a question before you want to see the population health?
I'll move on to that whenever you're ready.
You guys ready?
Yeah, I'll hold my question.
Are you sure?
Yeah, put it out.
Go
there.
ahead. He likes to interact.
So it sounds, like lots of rainbows and roses, but could you talk about some of the difficulties that you might have had, maybe connecting with the local population or developing protocols and programs that were, more readily adopted by the population?
Well, Vaughn,
A to B slide?
I'll put up a slide here in a second, give you an idea. I've always told people that in AMPATH, we've learned in Kenya how to move from A to B. And Vaughn, if you can put that up.
Yeah, I'll try to figure out how to do it. Hang on a minute. I'm going to figure out this one.
A lot of folks have the idea that, there it is.
Yeah, now let's see this one.
Yeah.
That one. Okay.
There's going from A to B, if that answers your question. You can see that here, and that's what it's like. The truth is we had every imaginable obstacle. We've been, everything that could go wrong goes wrong. We go backwards at times, but by just hanging on to the vision of where we need to be with our Kenyan colleagues, we've been able to get from A to B, but always with struggle. Now, I could give examples. Our difficulty with National Ministry of Health, County Ministry of Health, local community, tribal differences, and inside specific communities. There have been difficulties almost at every level, both within the community and the staff serving those communities. But there have been ways to work through those problems that have allowed us to move from A to B, and for them to own it and believe in it and feel like that they can make it happen.
That's interesting when you say you count as difficulties. What are the ways in which, when you think about getting them to work through those difficulties, what have been the things that have helped keep people on that moving toward B?
Well, I think one thing is to value their input and feel like that they not only see the problem, they own the problem, and their creative ideas are the ones that we need to listen to. And for example, our clinical officers, these are like, in the US, be like physician assistants. Over 95% of our care is not done by doctors, but it's all task shifted to physician, clinical officers are like physician assistants, and on down. In fact, much of our HIV care is actually now done by peers, where the HIV patients themselves are a major part of the provider network. And but the clinical officers feel burned out. They lose their motivation. They feel no sense of a career ladder. And so what we have done is we've gone back to the Ministry of Health, worked with the national agencies to develop a whole new curriculum and to provide an advanced practice certification for them that speaks for the excellence of the service they provide. Instead of just demanding they do that work, recognize them for that work, give them an advanced diploma, they get the prestige of that, their salary goes up, and suddenly they feel valued and like they're in control.
This presentation, Daddy, has the slide on the population health stuff. You want to speak to that, or you want to take?
Well, let me. Okay. I'll let you can put that up, but I'll introduce the topic.
Okay, I'm going to stop the share for just a second. We'll come back to it. Okay, so then they can see you better.
The issue is kind of what next. Here we are with wonderful drugs made available by the international donor community, available now to a provider network extending out in the villages. We were the first program in Africa to go door to door within the villages with village people, finding every single person with HIV and getting them on treatment. Fine. But it turns out that's just one part of the problem within these communities. The poverty is overwhelming. The number of additional diseases, be they non-communicable chronic diseases that are beginning to really show their face in Africa, like hypertension, diabetes, cancer, they are going to blow away, relatively speaking. The threat they represent to society is far more extensive than even HIV. And realizing that, how can we just keep polishing this apple of an internationally recognized HIV care system? Are we going to be satisfied with that? Or is that just a stepping stone to do what we ought to really be doing? And it's in that context, looked around, I think, two important insights. One was to realize, from having worked with HIV, rather than dealing with the sick person coming to the emergency room or to our office, we went into the village and found it, and therefore captured it early, got viruses under control. It stops the spread of the disease. It makes no sense to practice a Western style of medicine where you sit in the office and take care of sick people coming in. You have to partner with the community if you're going to do anything. And in that context, we begin to say that our patient is not the person coming in the door. Our patient is the entire population. And to be able, we're now responsible for about 4.5 million people in Western Kenya. And we've carved out a 1 million pilot right now. And we basically are saying, for that 1 million, we want to figure out what it takes, working with them and with government, to absolutely take care of everything. To give you an example, we are now the only program I know of that goes door to door and looks for mental health problems and knocking on the door. And these are village trained people that we've trained, and they will divide what they find into 4 buckets: severe depression, psychosis, drug dependency, or other. And I love the category of other, otherwise we wouldn't know what to do. We can get them all in 4 buckets by doing that. But then we'd start responding to what we're finding. And we're the only program in Kenya now that has AA groups run by Kenyans in the village, beginning to deal with alcohol dependency. And so we've done that with our cancer screening. Imagine the #1 killer in Kenya, cancer-wise, is cervical cancer. Totally preventable. And yet that's the #1 killer. And so again, we go door to door, and they even have women do self-vaginal swabs in their home and then do a PCR analysis of that for high-risk HPV virus subtypes and know who's at risk for cervical cancer to bring them in. And we're doing that across the board. And we work from the village up rather than in a doctor's office. And it makes all the difference in the world. So our focus is hypertension, diabetes, mental health, HIV, and one of the big ones, which you may or may not be aware of, is indoor air pollution in the developing world. Most of these women are cooking with firewood gathered in the village and unventilated kitchens and destroying their lungs. When they reach their late 50s, early 60s, when they ought to be a happy grandmother, they're dying in right-sided heart failure. And being able to, and that's a wonderful example. We have groups of women now setting, say 15 or 20 women, designing their own modified kitchen after we teach them what the problems are, and bringing an engineer from Purdue University to sit with them in the village and help them debate around and then have them build with their own hands a modified kitchen. And we've been going through this iteration to now the women have developed a kitchen that's decreased the pollutants by over 90%. And this year we'll start scaling it across the Nandi community. Only possible because we work from the village up. I can show you pictures of stoves developed at MIT every outstanding engineering school in the world that will give no pollutants when you burn firewood, but these women won't use those stoves. So we went down to the village and had the women invent the stoves, do it with mud, and do it the way they do it. And we finally have found a kitchen that could markedly reduce it, and it's theirs. But that's an example of problem solving at the community level. And we tried to use that way of approaching the practice of medicine. Let me just say that when you, well, let's show that diagram.
Okay.
You get a look at it.
This one.
It's the second slide in there.
Yeah, you just have to switch it forward. Okay.
Now that, if you can see that, it's a very busy looking mess. But in a way, it's kind of nice because it speaks to the mess we're in. With the cause of the work we've been doing, we had all kinds of little silos. We had a group doing maternal neonatal child health, another group doing HIV, another group doing income generating activities in village groups, someone else working on hypertension and diabetes. At the end of the day, we have all these little silos hardly talking to each other, touching the community. If you look in the center of the diagram, the idea is to nourish that tree at the end.
Right. Yeah, see right here.
And that tree, it shows that it's how do you create health and wealth for that family. And we see here people carrying water buckets to nourish a tree. They're carrying little buckets.
Right, yeah, right here.
Each little silo is carrying its bucket. And then we've got the notion, why not put all the water in this large tube that goes around and let that all come together as nourishment that is now provided by the Ministry of Health with a big bolus of water at the base of that tree. And you notice it's Kenyans doing it, and it's letting everything feed to empower the Ministry of Health to do what it ought to be doing. And that is basically the way we're trying to approach population health. And you can see the fruits of that are in the tree. Some of those are sustainability, food security, you can read income security. And at the end of the day, we've come down to realizing we've got to do three things if this is going to be successful. And incidentally, we're involved in bringing this up now for about 1 million people. You got to do three basic things simultaneously. One of them, one important pillar, is to create economic empowerment at the village level, where poor people can actually get by financially. And so we call this GISE groups, G-I-S-E. For the moment right now, it means Group Integrated Savings for Empowerment, GISE, G-I-S-E. But these are kind of a form of table banking where we teach these groups how to each contribute their own money into a little pot just to their group. Imagine 20, 30 people at the village. And I'll put in $1 this month, I'll put in $2, I'll put in 50 cents, whatever. A little money accumulates, and members of the group can borrow from that to start to either add a special fertilizer to their garden or to start a small business by the side of the road, whatever they need. And they pay back to their own group. They're responsible only to their own group. And it started with maybe circulating $10,000, $15,000. We now have 1,500 of these groups, and they're now loaning among themselves about $1.5 million, all at the village level. And their return on investment for the last 3 years has averaged around 30% per year, which is better than anyone else is doing that I know of. And you begin to see that the power of the village and how people can begin to bring themselves up. We're now moving, instead of these little groups, we're creating cooperatives of the groups, and look at the power of groups where there maybe 200, 250 groups, all part of a cooperative, and discovering the added power of that kind of arrangement. But the point is, one important pillar is get busy to work with the community to help improve their economics position. Otherwise, it's hopeless. Number two is take a rundown, dilapidated, dysfunctional ministry health system that's been just kind of deteriorating over many decades and reinvent it into a care system that anyone would be safe getting their care there, where you get safe maternal child care, safe care for HIV or hypertension or diabetes, rationally distributed between village all the way up to tertiary care if you need renal dialysis or you need radiation therapy or chemotherapy, to put that whole system together. So we work with the Ministry of Health to create a legitimate comprehensive care system. That's pillar number two. And pillar number three is very important. And it's the one that I feel like it makes all the difference. And that is to move this process toward universal health insurance. Not health insurance, but universal health insurance. And when we talk about health insurance, we mean health insurance for the informal segment of society. The informal sector of society are those that don't have jobs with a salary each month. People with an employer, the employer pays their health insurance. But if you're out on your own and you have no one giving you a salary each week or each month, you have no health insurance. And where I work, 90% of the people are unemployed, 90%. Wow. And if you're going to work in that system and you're going to offer universal health insurance, it's the only way it can work. With universal health insurance, enough money flows to keep that Ministry of Health system going. With community economic empowerment, there's enough money to buy the health insurance. You'll love this policy, and I'll finish with this for questions. The policy we have now, insurance-wise, offered by the government of Kenya, is for $5 a month, the entire family has access to everything, from village all the way to tertiary care. If you can imagine health insurance for $5 a month, giving you everything you need. They've got the policy, but the ministry could never deliver it. Now we can. And $5 a month is in reach for these village economic empowerment groups where they can actually pay that premium. So we're just trying to put all these pieces now together in what we call population health with universal health insurance. I no longer talk about population health without that second sentence, because to have population health without universal entitlement, then who can use it? And without universal insurance, there's not enough cash flow to sustain it. And without economic empowerment at village level, no one can pay a premium. So it becomes obvious to do this, you've got to do all three at the same time.
I'll pull this back. What are you thinking?
You want to come help me?
Can you imagine?
I mean, it sounds very impressive. And do you have some sort of political backing to do all this kind of stuff in Kenya?
They have some kind of what?
Political backing.
Not really. You know, the truth is, and I think you'll find this in many situations, even within one's own university, it's unlikely that government will get great ideas and ask you to go effect them. The most we can hope for is to pursue our dreams with the community and the more local ministry levels, and hope we don't get torpedoed or stopped at the national level. So far, we've done fairly well. It's not without bumps. But generally speaking, I would say in Kenya, we have not run into immovable objects. For example, when this premium comes in for the insurance product, where do you think that money is going to go? And it too often goes into pockets instead of where it needs to go. But I won't go into details of that, but we had to be very thoughtful of developing MOUs with government where the money coming in for this primary care goes into a separate bank account. Even though it's their money, let us be oversight reviewers to at least see what you're doing, to kind of hold to some level of integrity and transparency so that money goes right back where it needs to go. I would say I don't see government as an obstacle, but at the same time, they haven't been an awful lot of help.
Yeah.
And that's okay. That's okay. As long as they're not just knocking our legs out from under us, I think the Kenyans at the working level and at the county level and certainly at the village level, they get it. And as long as we're not being stopped nationally, we can keep moving forward. If it gets enough momentum, I think they'll dare not touch it.
Yeah, and the one thing that Mom came in and showed me a little note just to emphasize that Moy University is a public hospital.
Everything is.
Everything's public. So even though Daddy's talking about government in terms of political leadership, the Ministry of Health and the university that is a part of this whole system is a public system. So it is government working, you're working with government to do this, but the politicians are kind of not paying attention.
Yeah, if you look at members of parliament, and if you look at government in Nairobi, it can be really tricky.
Yeah.
But when we get closer to home, it is all government and it's all Kenyan run. This whole thing, the leader of everything I work in now is all Kenyan. We basically work as cheerleaders within the fabric of the system, help with fundraising, help think through ideas and possibilities, but everything is run by Kenyans and everything is organized toward sustainability, even without the donor community and without our presence there. The success is their ownership and their ability to renew it in the years ahead without us.
Yeah, one of the things that strikes me as you're talking about these local villages, another thing that you talked about with me is the Indiana community and local global.
Yeah.
As you guys know in the class, we kind of, and even at the school, we talk about, do you need to have a global health class and, how these ideas around what's global and what's local. And I'd like for you to talk about that a little
bit. It's a good point. You begin to realize as time goes on, we're all one genome. And I don't care where you are in the world, there are a lot of cross similarities in the problems. And you'll find a lot of people now in North America talking about population health as well. It's been difficult to tease out at all times what they're talking about, because many times when they say population health, they mean the population that owns their particular insurance product rather than the population that lives in a certain geographic or catchment area. But what we have done with the movement in Western Kenya is to partner with several other communities here in the U.S. For example, the county that surrounds Indianapolis, the county, Travis County, that surrounds Austin, Texas, to have several of these counties join with us and do this population health in the U.S. and in Western Kenya simultaneously. And we exchange learning, ideas, lessons learned, self-correction, and we call it now local global, with the idea that we can do things in Africa that need to be tried that you can't do in the U.S. for a variety of reasons. And you have things you can do in the U.S. for sure. Excuse me, Vaughn. We do a lot of things in the U.S. that we can't do in Africa. But look what we can learn from each other in information technology, teleconferencing, using Zoom like we are right now to do teleconsultations at the village level. I work in many places with no electricity, but all of them now are on internet. Well, how do you do that? All you do is a solar panel on top of the building and then wire that down to a router, hook that to the national telephone grid, and then suddenly you've got Wi-Fi. You may not have electricity, but you got Wi-Fi. And now we can introduce the Zoom platform and do our training, continuing education of our providers at the village level. everything I do now is on tablets. I don't even use paper.
Yeah.
Even out in the most remote village setting, I work without paper. And that's all from lessons learned in North America, brought to Africa. We're going to learn things about the safe care of hypertension, diabetes, early detection in populations that need to be brought back to North America. And so we're really beginning to look at a partnership between North America and Africa, where we call it local global, where it's no longer a matter, I'll do global health, so I'm going to go to Africa. Well, you know, sometimes you just need to go across the street to be engaged in what needs to be done. And if I said to Vaughn, and I really believe this, I really believe after these years that global health is a pair of glasses or prism through which you look out and see the world. And you see people a certain way. And I don't care if you're in Kokomo, Indiana, or if you're in Jalalabad, Afghanistan, or if you're in Eldoret, Kenya, or Austin, Texas. It's the same. And if you're looking at people as part of the world community and what's the right thing to do for their health, then I think one can be engaged in population health and global health. I like to tell students, if you have to travel to do global health, you miss the point. You may travel, you may not, but we can all be busy doing what I call global health.
That's great.
Yeah.
I like the idea of local global and what you describe about the insurance scheme in Kenya, where the government the individual contribute about $5 a month, and they have access to free healthcare in their community. US, have you have a problem with health insurance, especially among the minority? And have you tried this scheme in any of the countries you are working with in US?
Yeah, Wishart.
We have. I spent 30 years as chief of medicine at the largest public general hospital here. And we basically just turned the property tax money for healthcare into an insurance product and created it, we called it Wishart Advantage. Wishart was the name of the hospital at that time. And so the patients suddenly had an insurance cover with the property tax money rather than just, quote, free care. And then we're able to take that paid for care and mix it with commercial, because suddenly we ended up with a one standard system of care where poor people, wealthy people, anyone with insurance could all come to the same site. Now, we've done nothing like what I'm talking about, as you might guess, with this population health, where you get engaged down at the community level so preemptively to try to really prevent through early detection, avoid secondary avoidable complications and so forth. We were not engaged in that in those days here in the US. So I think much has to happen, obviously, and you know better than I, so much has to happen in the US to create a healthy insurance environment that includes everyone. And we'll work hard to try to do that in Western Kenya. And hopefully we can learn enough and be stimulated enough by the possibilities that will end up with universal entitlement in our communities here in the US, as we will in Western Kenya, and an approach toward practice that worries about the entire population. Means you worry, do they have jobs? What kind of contaminants are in their environment? Are their children able to go to school? What's their nutritional status, as well as the traditional things we think of as healthcare? And I could tell you, it's not as much fun to take care of someone coming in with a stroke, even though I know how to do that. It's much more exciting to get into the home and to be measuring the pressure 10 years before the stroke, getting them on treatment and avoiding that stroke down the road. And that approach to medicine is much more satisfying. And that needs to be done in North America as well as Western Kenya.
Yeah. Other questions? Jennifer, I see your, is that your Samsung still out there?
Yes, I'm still here. love the point that was made about the local global concept, because I think so many times from a local level you get so just mired down into what we have to do just for our community. And so I think the perspective of the work that we do on a local level is really global public health and vice versa. That really struck me, and I really appreciate that. That helps kind of change my view of the work that I get into every day. So thank you for that.
That's great. Yeah, I'm looking at who's on. We just have a few people left, and I know that this is a short week for folks, and there may not be a lot of people who even see this lecture this week. But as we were kind of getting in, is there anything else, Daddy, that you would want to say to these few students that are on here, and then others will see this video? What would you want them to know about being public health leaders? And
well, first of all, I look forward to meeting them when they come for their rotations in Western Kenya. We welcome you. And, but you know, the future of what really needs to be done in North America, Sub-Saharan Africa, and many parts of the world is really being passed into the hands of the young people that are taking this course right now. And I find it very heartening, exciting to see another generation of people. The most important attribute in the world is to care. As long as you care, you'll find a way and make a tremendous difference.
Yeah. Well, folks, I thank you for sticking with us today. I think we'll kind of look at the time, and we're kind of coming in at the end of this hour. I will tell you that I put a link on the course website for Module 5, Lesson 15, I think is where we are, to an article that describes the 3 pillars that Dad talked about. There is a physician by the name of Laura Rule, who is finished her master's in public health and maternal and child health at Chapel Hill a few years ago. She's an internist and a pediatrician, but she's someone who is moving into a leadership role on this agenda around 3 pillars. And so she's the lead author on that piece. There are other people, and I would strongly encourage you, if you're interested in learning more about this work, there is a great website on AMPATH. It's AMPATH, and that's Academic Model Providing Access to Healthcare. If you Google that, you'll find their IU Kenya partnership. If I had more time and more opportunity, I would, and who knows, I might do it yet. I might pull my mother in and have her talk about the work that she's done with child life, which is another aspect of what they've done in Kenya. And then another person who's here at the house, but he's not feeling so well, is my brother. And when you talk about information technology and how you're doing what you're doing on tablets out in the world, my brother, Burke Mamlin, who's also an internist at Indiana University, has been really at the forefront of creating open medical record systems and ways of learning through the amalgamation of data about how to improve the quality of care that's offered. And his work is being used by Paul Farmer, Partners in Health, and all sorts of programs.
He started in one of our clinics, and it's now in 60 countries around the world.
Yeah.
And through his help, even our computer system is the largest computer data repository in all of Africa. Yeah. It's because he helped us get started many years ago. Yeah. But he's moved it worldwide.
Yeah. So I just want to say it's a real treat for me to be able to share a little bit of what makes my passion what it is, because I have seen what someone with commitment, someone who leads through love and cares for the people that need to be cared for, and it makes a difference. So thank you all for letting me share him and a bit of our story.
Take care.
Thank
you. Thanks for sharing.
Thank you.
Great to meet you. Thank you very much. Enjoy your time.
You guys have a great Thanksgiving.
Thank you, you too.
Okay.
You too.
You too.
Bye-bye.
You did.
Yeah, thanks, Daddy.